Kindly proceed with your talk, sir. Over to you.
Thank you, Aisha, and it gives me great pleasure to come on this platform, Clirnet, and share my views. So, as Aisha already summed it up, we are really discussing the measurement, and there are two basic measurements, that is the incidence and the prevalence. These are very simple measures, but if used properly, it can yield a wealth of information. Firstly, for managing the public health burden, and secondly to monitor how particularly a communicable disease is behaving, whether we have been able to interrupt the transmission or the transmission is going on or increasing after the intervention. And it helps us to evaluate the intervention also, whether the intervention has been effective or it is not as effective as we anticipated. So today I'll be, after discussing the basic principles of incidence and prevalence, I would be using the present past 5 years data. I will be trying to capture by using the simple methods of incidence and prevalence, not only how the disease burden as well as how if we can combine these two metrics, we can also generate some hypothesis regarding causation. So using the illustrative example from the COVID pandemic, will be using some compiled data which is in the public domain, which anybody can recheck. And so just to show how the simple measures can help us better than any complex mathematical models to give a realistic picture. So I'll be sharing a screen, and I'll just let me see if I can share the screen. So I think I am able to share the screen.
Yes, sir. It's just not in the full screen mode, so just you do that, sir.
So anyway, now I think it
Yes,
is
sir.
there. So this is the topic as introduced, and this would be the scope of our discussions. The incidence, as already mentioned, new cases. It is helpful in monitoring transmission of infectious diseases in the short term. And also, of course, we can measure the incidence over long terms also, which are known as secular trends, like lifestyle changes, smoking, tobacco, alcohol use, chronic diseases, any, and how the decadal trends. So that incidence can be long term also. For communicable disease, it is short term incidence, new cases, and it can also used for evaluation on efficacy of control measures, the interventions. And prevalence is the total burden at a given point of time. Like you carry out a survey, you want to see how many people have got visual impairment. If you want to plan cataract services, how many people have got cataract. So you carry out a survey in an area, and then you can plan so many cases, so many eye surgeons would be required. So old and new cases, particularly for chronic disease, and disease burden for planning of health services, and comparison of burden across different regions. And let us say, as I was saying, we can use this, I'll be demonstrating how we can use it. The major in the present pandemic to generate hypothesis. In the present pandemic, we have seen in the present pandemic. And uh, as you know, presently, the world is facing an obesity crisis, particularly the Western countries, very high obesity BMI rates. And if you want to know the prevalence of overweight, what percentage of the population are overweight at a given point of time. So that would be the people who got overweight within that short period on people who are already overweight earlier, new cases of overweight. So that will give up the prevalence. And I'll just illustrate how correlating with the incidence or we can generate a hypothesis. And incidence can be at a yearly incidence, monthly incidence, and you can have a unit of time, that in this month how many new cases, or in this year how many new cases. And then it can be cumulative incidence also. Over the 6 month periods, how many new cases had accumulated. So these are the various ways which we can improvise, and according to our requirement. And methods, as I said, for incidence, you have to have a continuous surveillance system. You have to have an infrastructure to case reporting, case definition. If you want to calculate the incidence of death, you should have a proper death certification. You may be aware of the certification of death. And limitations are also, we'll see what are the limitations. So describe, as I said, these are the magnitude and health problems. Etiological risk factors. I will just demonstrate how combining these two measures for different variables, we can have a hypothesis or etiological factors and data for planning, implementation, and evaluation. We should know it can provide as a compass where we are going in the right direction or we are to change our strategy. So we can measure many types, demographical variables, different populations, different age groups in a particular, whether it is affecting any particular age group or any particular demography more than any other population. So that can also give a clue to it. And risk factors, we can also measure the risk factors, number of smokers. As I said, one of the risk factors in this pandemic was the obesity. So that we can measure the prevalence of obesity and correlate it with the incidence, which we will just demonstrate. So, and very important is like limitations is if we do not have a proper death certification, that or data, it would be difficult to trust the data. So incomplete reporting, it may start with the incomplete reporting case definition, inaccurate, or death certification, we cause of death not properly entered. So these are, we all know. And choosing a single cause of death, as we have seen in this pandemic, person dying of anything, just single cause of death has been given as a COVID death. So this also requires, you see, requires introspection, whether we have erred in defining the cause of death. Measurement of morbidity, incidence, number of new cases divided by population at risk. So when you calculate either incidence or prevalence, you should have basically three inputs. One is the new, for incidence, it should be the new cases. And they have, that would be the numerator. Then the total population at risk, that is the denominator, and a multiplier, percentage per 100 or per 1,000 or per lakh or per million, depending on the quantification of the new cases. If the cases are very less, like maternal mortality rate, so you have numerator as the number of maternal deaths and denominator is number of childbirths and multiplier is per lakh cases per lakh. So if it is a routine, some cases which you have got, say food poisoning or attack rate, so you can have a multiplier per 1,000. Numerator is the total new cases, denominator is the total population which are exposed, and the multiplier can be 1,000 or 10,000 or per lakh. So we have to mention, you have to write, when you are mentioning the incidence, you have to write these three things. So it refers only to new cases during a given period, for maybe month, per year or decade, defines the population and may include spells of sickness, like either it may be spells or it may be only one person will be counted once only. Suppose I get malaria in the month of January and then again I get malaria after 3 months. So I have got two different spells of malaria. So depending on the disease, like it is important to know the malaria transmission, so it may be counted a number of spells. The same person may be counted more than once. Prevalence includes both old and new cases, and point prevalence and period prevalence. Point prevalence means today I carry out a survey of, say, blindness. So within 1 month, and that prevalence would be during this month, there were so many cases. And period prevalence may be over a period of 6 months, cumulative, so many prevalence, old and new. These cases have entered at one time, and this is the cutoff time, and in this time they were the. So usually for prevalence, we take it point prevalence. And it can give a picture as a snapshot, what is the burden at a given time. Whereas incidence is you are continuously watching the dynamics of disease. Continuously you are reporting the cases. The cases are being reported, compiled, and it gets into the database, and in a graphical form, the timeline it is showing. So it has to be a continuous. So incidence is something like a video recording, and a prevalence is a snapshot. At one point of time, it's a click. So you will have a better, yeah, if you combine the two, how the cases is unfolding. So for that, you require a video recording, and that is the incidence in statistics. Incidence can be compared to a video recording. So at a new events occur in a defined during a specified period of time. It can be monthly. If it is a very acute outbreak like cholera, I think it may be weekly, or hepatitis, or it may be monthly, or it may be yearly, depending on the disease and or your requirement, how quick you have to act, a public health reaction team. So this is the numerator, new events, number of persons, denominator, and a multiplier. And the numerator strictly refers only to first events of disease. That is, in case if it is a disease which you can get only once, but as I said, you may get an attack of malaria more than once in a year. So it depends. Either you may count spells or you may count, say, new cases of, say, I get first time discovery of, say, hypertension. In a year, this is discovered. So I cannot be counted again if you are only counting for incidence. So I was start of the year, I was free from hypertension. Midway, I developed hypertension. I will be counted once only, and end of the year also I will be having. But it is. But if it is a spell of an infection, it can be counted twice. When calculate incidence, those having disease in the population start a baseline and excluded. So incidence, you are not taking the old cases. You are only from the denominator. Prevalence is, of course, number of people with a disease, old or new. You are only at one point of time. You are not bothered whether it's a new and old. And different prevalence is more expressed as a proportion. Proportion means part of the whole portion, how much are having. Point prevalence and period prevalence I have already discussed. And here you see in chronic diseases, sometimes, prevalence, I'll just explain that it's the dynamic process of both the prevalence and incidence. The prevalence is it can take a sort of a container where the new cases are being, like a tap, water is going into this container, and water is coming out from the bottom. There are two holes. One is the recovery. People recover, so they are not, in case of a survey, they will not be counted because they have recovered, or people die. So if a disease has got a very fast recovery, very like a common cold, 3 days recover, you will not have a very high prevalence of a disease. Or if a disease is very fatal, person dies like a rabies, so 100% mortality. So you will not have at a survey at one point, you will not get many cases of rabies, though the incidence may be very high. In fact, in such cases where there is a very transient period where the person is sick, and either he recovers very fast or he dies very fast. So it will not be caught in that snapshot. So the prevalence, the incidence will almost approximates the prevalence. Because, but in a disease like diabetes, where now with treatment, the person can lead a normal and prolonged life, and the death also can be prevented by treatment. Now, AIDS is also becoming like that, where the treatment is there. So in spite of a good treatment, you will be increasing the prevalence of the disease. Whereas earlier, what happened long back before diabetes treatment might have been available 50 years ago, people of diabetes may be not maybe succumbing to the disease due to, or may not be recovering. So, but as the medical advances increases, so you remember, you cannot control it. You may increase the burden, but and improve the quality of life. So you will require more planning for treatment services, for chronic treatment services. So this is the paradox. Like in a chronic disease conditions, the advances with treatment, you will be increasing the prevalence, and you should be prepared for that. You cannot let people die. I mean, that is the Darwin's law, survival of the fittest. So here we are interfering with, and we should be ready to pay the cost of that, um, uh, bypassing Darwin's law. You will have a higher and higher prevalence, and you have to plan for this. So incidence So prevalence is equal to incidence multiplied by duration. If a duration is very long, it's your prevalence will keep on increasing. So application, as I said, I'll be trying to demonstrate it, inputs, distribution of cumulative incidence of cases per million across countries. We had been plotting the data, which was available in the worldometer. And prevalence overweight, we took across many countries, 180 countries. So we will be showing only few continents, different continents, because when we compared the tabulated the data, we found there was a vast difference in the incidence. As I said, no, incidence differing from different demographic, different population can give a clue to the hypothesis. And median age across countries. So age is also one demographic factor. So as we know, the Western countries have got a higher age, and Asian African has a younger age. So that can also affect the incidence of, say, infection like COVID. And also we have to took that intervention from the world in data. We had the rollout of the vaccines in different countries, mass vaccination. And also the overweight also we took as BMI, basal metabolic body mass index. More than 25 we took as a overweight. And this data is available in the WHO site across all countries. BMI and median, the average BMI country-wise is available. So all these are very hard data which are available in the WHO. So many data are there in the public domain. If you can use it intelligently, you can yield a lot of information. So that is prevalence. That is from the WHO side, they keep on doing the estimates, and at any given point of time, what percentage of people are above BMI 25? That is the overweight percentage. That becomes the point prevalence. So that is, and then incidence very easily from the worldometer data, country-wise, we were getting the monthly cases and deaths from COVID. And we tabulated it, and just eyeballing the data without any fancy statistics, without any complex formula, just eyeballing the data gives a lot of, nowadays, the people are going for very complex models and mathematical black box, whereas incidence and prevalence, simple data, just tabulated, it can yield a very neat and clean, uncluttered picture. So this is the first year I would like to show. I hope it's not very complicated to see. The country is on the left, and we have selected few countries because they are plotted for almost 180. So topmost is in light blue is the Western countries. They have got a different age. They have got a, and in between in the light brown are the Asian countries, and lower down is the African countries. And the next column is we started comparing from May 2020 in the early pandemic. We this death per million. First column is incidence. That is cumulative incidence as on May 3. Death per million means how many deaths, numerator, and denominator are the total population, and multiply by 1 million population, so that it can standardize, so we can compare across countries per million case. Otherwise, if you say total deaths, India is a very vast country. It will always had. China is a vast. Small country will have less cases, but that depends on the size. So once you standardize it into incidence and prevalence, the data become comparable. But so here you see in the beginning, what we see is, I'll just show, this is the data in May, and the second column is the data after 3 years. That is after 2 years, 2022, August. So if you see the data in the Western countries, which is having a higher age, the fourth column is the median age. And and if you see, very interesting things are coming out. If you see the in the beginning of the pandemic, also the Western countries are higher mortality per million, a higher number. Sorry, these are the number of mortality. We have taken mortality. Here we have not. Sorry, we have taken mortality because that is a hard data. So mortality from COVID, incidence of mortality. That is, the Western countries were having very less compared to the very high compared to the Asian and African countries. And African countries were having the lowest mortality, 0.4 per million. And then if you see the fourth column is the median age, and the fifth column is the be, percentage, that is the prevalence of overweight in percentage. So if you see the Western countries, almost all the Western countries have prevalence of overweight over 60%. Whereas Japan, an Asian country, Japan, though it has got a higher median age of Japan is 48, which is higher than the Western countries also. They are the largest longevity, and they had a very low mortality. If you see the Japan, that is middle, Japan had 297 compared to say USA 3287, in spite of a much higher age. Why? Because their obesity, this obesity was much less. BMI overweight was 27 compared to 67 in USA. And on the other hand, I think Brazil I have included. Brazil I have included. Brazil has got a lower age. If you see, it's a developing, but it has got a higher obesity. And in August, its mortality from COVID was almost same, or not higher than the Western countries. Brazil, which is in the top, fourth from top. So this is very illustrative. Like this is the overweight, and the last column is the vaccination coverage. So if you see, the Western countries had many times higher vaccination, and the African countries had the lowest vaccination. And the mortality throughout the pandemic in the African countries were the lowest in spite of lowest vaccination, because they had a very low BMI compared to the Western countries, except for say South Africa. It had a high, but its mortality, if you see, compared to the African, it had a higher mortality, other African countries, in spite of a higher value. And similarly with Egypt, it had a higher BMI. Egypt and South Africa were the two countries with higher BMI. And it had a compared to other African countries had very low. So this is just a simple which shows the prevalence and incidence, cumulative incidence and vaccination status we tried. And here is a very interesting charts from here onwards. So as I said, key incidence we can cover, evaluate the intervention. So here we are evaluating the after the mass vaccination. These are the these are the incidence, month-wise incidence from 2020 onwards to 2022. And in between there was a vaccine rollout. So 1 year before the vaccine rollout, left side, and 1 year after the vaccine rollout. This is at Japan. So almost 80% plus vaccination coverage. If you see the cases, new cases, these are the new cases. There's hardly any cases before the vaccination rollout. After the vaccination rollout, there have been more cases, and after a few months of vaccination rollout, there are very high peaks. So that this figure should tell us that the intervention is not working. Maybe many reasons, maybe say mutation, Omicron, many reasons. So this is one point, that vaccine, and later also it was obvious that it is not preventing transmission. The next year was that, okay, it doesn't prevent transmission, but it prevents deaths. So the next graph is daily deaths in Japan. Vaccination, there were some deaths on the left side. Before rollout of vaccination, in red circle, semicircle, there are some deaths. But after the year also, there are also deaths. And some of the peaks are much higher than the pre-vaccination area. So this picture shows incidence trend show that intervention did not make as much, unfortunately, as we expected. And this is Israel. Israel also had a very fast vaccination rollout, very good control. So before the vaccination rollout, left side, hardly any cases. And after the year, there are peaks. After that, definitely after 5-6 months, the effect of vaccination has gone, and there are peaks in cases, because people also mixing how long you will have lockdown. So those can be the reasons. And you see the deaths also. Left side, there was one peak of death. Uh, After vaccination rollout, there are number of peaks of deaths. So it did not have much. And maybe they had actually death, any cause of death was being attributed to. So the case definition was also not very correct, accurate. Anybody without symptoms They were so whatever it is, whatever the country before and after, whatever the standards of enumeration, whatever the data, the same country is its own control before and after. So this data throws a better picture, and we can be more of our inferences. In the same country before and after, it is having that this data is in the public domain. I don't know, they are making so many complex mathematical models to show vaccine prevented deaths, vaccine. But here the data, clean data is in the public domain, is not telling the same story. This is a very interesting Australia, because this came in the light that tennis player Nojavic, what is his name? I just get mixed up. So Nojavic or Joe Javik, he was refused entry to Australia, and he had the last laugh. So before the year, there were hardly any cases, because Australia, New Zealand, they were very island nation. They were very strict with their lockdown. So there were no cases. They had rolled down mass vaccination. After a few months of vaccination, there are multiple peaks, Australia. And unfortunately, the deaths also are there in Australia, because they had very few deaths because of the strict measures. But after the rollout, it did not prevent deaths. So this is Australia, many countries. This is Singapore, again, very illustrative. Now again, they say there is a new variant, but in what way vaccine rollout helped before and after the cases? These are the deaths. All the deaths in Singapore have occurred after vaccine. It did not check. Maybe misrepresentation or misclassification of death certificates and all, whatever it is. But this whatever data available public domain. This is Malaysia, same story. This is again Malaysia, hardly any deaths before vaccine rollout, all the deaths after. This is Sri Lanka, our neighboring country. They hardly before the vaccine rollout, they were after the vaccine rollout, number of cases. This is again deaths in Sri Lanka. So this is Taiwan again. Cases, hardly any cases, but after some maybe giving very transient protection, but after the common coronavirus keep mutating. These are That's also Taiwan after. So conclusion, counting and converting numbers into incidence and prevalence rates generate valuable measurement. This can be used for comparing disease transmissions across different regions. As we saw in Western countries had very high mortality from COVID in spite of higher vaccine because of the obesity. Simple tabulation and graphical representation can be valuable clues for further exploration. And subsequently, when this graphical presentation is showing obesity, they did studies, and at the individual level also, they found that obesity was the highest predictor of mortality from COVID. Limitations, accuracy of defining cases. There was a lot of inaccuracy in the present pandemic. Firstly, case definition and death certification also. People died more with COVID than due to COVID. The comorbidity scale, not the virus. So here we have to, lesson is to take care of the comorbidities. There may be number of viruses coming and going. So every time the best is to take care of the comorbidity. So these are some of the references supporting this. So this obesity, as I said, this initial eyeballing showed, and there have been detailed studies which shows the obesity is the biggest predictor of mortality and severity from COVID. Secondly, this I had also published this trends which is there. And thirdly, there is a supportive paper to show that increase in COVID-19 are unrelated to levels of vaccination across 68 countries and 2947 counties in the United States. This paper published in European Journal of Epidemiology as early as 2021 when vaccines were rolled out. So these are some of the references just to explain this paradoxically. I think I have finished, and I think I can stop there. Thank you. I can take any questions if there.
Hello, sir. Thank you
Yeah.
so much, sir, for answering all the inquiries of the participating. Thank you so much, sir, for your wonderful deliberation and such an informative speech, sir. And your talk was really informative. Thank you very much, sir.
Thank you. Thank you.